Welcome to the deep dive. We're diving into some really core OBGYN topics today, the kind you absolutely, positively need to have down cold, especially if you've got the NBME shelf exam coming up. Think of this as hitting the high-yield highlights.
Exactly. We're focusing sharply today on gestational trophoblastic disease, STIs and vaginitis vaginosis, breast disease essentials, female patient health maintenance, the screening stuff, ethics, menopause, and pelvic relaxation. A lot to cover, but all crucial.
And our main guide, our roadmap for this, is First Aid for the OBGYN clerkship. We're going to mine it for those key nuggets, the really important bits that are likely to pop up and you just have to know. Okay, let's jump in. Gestational trophoblastic disease, GTD, what is it broadly?
Right, so GTD is basically a spectrum. It's all about abnormal growth of the trophoblast. Those are the cells that normally form the placenta. It ranges from generally benign conditions like hydatid form moles to the more serious gestational trophoblastic neoplasia, GTN.
And GTN includes things like invasive moles and choriocarcinoma.
Exactly.
Yeah.
Invasive moles, choriocarcinoma, and also the rarer placental site trophoblastic tumor, PSTT. Let's start with the moles first, though. Complete and partial moles.
Okay, complete mole. What's the classic picture? I'm thinking maybe 12 weeks, vaginal bleeding, uterus feels way too big, maybe high blood pressure, no heartbeat on Doppler, and that ultrasound finding.
The snowstorm pattern. Yeah, that's classic. And genetically, this is fascinating and key. Nearly all the genetic material comes from the father. Usually it's 46XX. An empty egg gets fertilized by a sperm, and that sperm is DNA duplicates.
So no maternal DNA from the egg itself.
Right, or sometimes 46XY if two sperm fertilize that empty egg.
Yeah.
The big takeaway is, because of this, there's never a fetus in a complete mole.
No fetus, but super high beta HCG levels, right? Much higher than a normal pregnancy. And those descriptions of grape-like vesicles?
Grossly and microscopically, you see those hydropic, swollen villi, lots of trophoblast growth, but no blood vessels within them. That's characteristic.
And those sky-high HCG levels can cause other issues. I remember reading about zebra alerts.
Yeah, our source points those out. Things like really severe nausea and vomiting hyperemesis gravidarum, or even thyroid storm symptoms, because HCG can actually cross-react and stimulate the TSH receptor.
Interesting. Risk factors, extremes of age.
Extremes of maternal age, very young or older, and having had a molar pregnancy before definitely increases the risk.
So you diagnose a complete mole. What's the management?
Prompt uterine evacuation, usually a DNC, suction DNC. And then, this is critical, very careful HCG monitoring afterwards.
We're careful.
Weekly blood tests until the HCG level is undetectable for 3 consecutive weeks. Then, you switch to monthly checks for 6 months. An absolutely essential, reliable contraception during this entire follow-up period.
Why the contraception?
Because a new pregnancy would obviously raise HCG levels, and you wouldn't be able to tell if it's a new pregnancy or recurrence or progression of the GTD. And don't forget RhoGAM for Rh-negative patients. The exam tip, complete mole genetic material, is all paternal.
Got it. Now, partial moles, how are they different?
Partial moles usually do contain a fetus or at least some fetal parts. They often present a bit later than complete moles. And genetically, they're typically triploid, usually 69,000 XXY. So they have both maternal and paternal DNA contributions.
Okay, so maternal DNA is present in partial moles.
Yes. Treatment is similar, though. Prompt DNC, followed by the same HCG monitoring protocol as for complete moles. The key difference to remember for partial moles is that fetal tissue is usually present.
Right. Now, what if these moles turn malignant or invade? That's GTN territory.
Correct. An invasive mole is essentially a hydatiform mole that started to invade into the uterine muscle, the myometrium, or blood vessels. It's malignant GTN, and it can metastasize.
How often does that happen?
The risk after a complete mole is higher, maybe 15–20%. After a partial mole, it's much lower, more like 1–5%.
And how do you manage an invasive mole? Is it another DNC?
Actually, no. DNC isn't recommended for treatment because the mole has invaded the muscle, and there's a high risk of perforating the uterus. Instead, you start with a metastatic workup chest X-ray, maybe CT scans of the chest, abdomen, pelvis, brain to see if it's spread.
And the treatment itself?
Chemotherapy is the mainstay, usually methotrexate or actinomycin D. And the good news is the prognosis with chemo is generally excellent. For women who are done with childbearing, a hysterectomy might be an option, sometimes combined with chemo.
Any chance of it coming back in a later pregnancy?
There's a small recurrence risk, maybe 1–2% in subsequent pregnancies.
Okay, let's quickly recap the signs and symptoms that should make you think mole.
Think abnormal, often painless, first trimester bleeding, sometimes passage of those grape-like vesicles. Preeclampsia showing up before 20 weeks, that's a big red flag. severe nausea, vomiting, maybe those thyroid symptoms, uterus larger than expected for dates, and of course those really high HCG levels, often over 100,000.
And diagnosis relies on.
IHCG, sometimes the coical lutein cysts, seen on ultrasound, no feel heartbeat, that classic snowstorm ultrasound appearance, and ultimately pathology showing the grape-like vesicles.
Got it. Let's shift to choriocarcinoma. This sounds much more aggressive.
It is. It's a very aggressive form of GTN. And what's tricky is it can happen after any type of pregnancy molar, normal term pregnancy, miscarriage, abortion. So you have to keep it on your radar.
How might it present then?
Often with abnormal vaginal bleeding that persists or starts up again months after a delivery or abortion or even a treated mole, and a positive pregnancy test when there shouldn't be one.
What's the key difference pathologically?
Histology is crucial here. You see sheets of abnormal trophoblasts, lots of hemorrhage and necrosis, and this is key novoli that distinguishes it from moles, and it loves to metastasize early. Lungs are common, but also vagina, liver, brain.
Diagnosis sounds like it hinges on HCG again.
Yes, HCG levels that are rising or plateauing when they should be falling after a pregnancy event. Plus, no fetal heartbeat, if relevant, maybe uterine size issues, and definitely requires a full metastatic workup.
Treatment for chorio, similar chemo.
Yes, chemotherapy is primary, often methotrexate or actinomycin D, maybe multi-agent chemo depending on risk score. Treatment continues until the HCG is undetectable. Hysterectomy plus chemo is an option for those finished with childbearing.
What's the prognosis?
Actually, pretty good. Remission rates are high, especially if it hasn't metastasized widely. Treatment decisions are often guided by a FIGO scoring system. Low risk gets single-agent chemo, high risk gets multi-agent. And monitoring is longer HCG checks for a full year after normalization, with reliable contraception during that time. Exam tip, sheets of trophoblasts, novoli, think choriocarcinoma.
Okay, and the last one in this group, PSTT, placental site trophoblastic tumor.
Right, this one's rare. Can pop up months or even years after a pregnancy. It's characterized by infiltration of intermediate trophoblasts into the myometrium. They stain for human placental lactogen, HPL. Again, novoli.
But the HCG is different here.
Yes, that's a key differentiator. HCG is only slightly elevated, not the huge numbers you see with moles or often with chorio.
Management.
Hysterectomy is the main treatment, often followed by multi-agent chemo. Prognosis is unfortunately less favorable if it recurs or metastasizes, and treatment is based on FIGO staging, not the WHO risk score used for chorio.
All right, that's a really solid run-through of GTD. Let's pivot now to another huge topic for the shelf. STIs and vaginitis vaginosis. Basic stuff first. How are STIs spread?
Generally through close, intimate contact. We're talking transmission of bacteria, viruses, parasites, usually involving mucous membranes.
Okay, let's start with a big complication. Pelvic inflammatory disease, PID. What is it and why is it such a concern?
PID is essentially an infection that ascends from the lower genital, tracks the vagina and cervix, up into the uterus, fallopian tubes, and ovaries. The major concerns are the long-term consequences. Scarring of the tubes, which leads to infertility and a significantly increased risk of ectopic pregnancy.
What bugs usually cause it?
The classic culprits are Neisseria gonorrhoeae and Chlamydia trachomatis. Mycoplasma genitalium is increasingly recognized too, but often it's actually polymicrobial. Multiple organisms are involved.
How do you diagnose PID? Is there a definitive test?
It's primarily a clinical diagnosis. You're looking for a lower abdominal or pelvic pain combined with tenderness on the pelvic exam, specifically cervical motion tenderness, uterine tenderness, or adnexal tenderness.
What other findings support the diagnosis?
Things like fever, usually over 101 Fahrenheit, or 38.3 Celsius purulent discharge from the cervix, maybe elevated white blood cell count on labs, or evidence of a pelvic abscess on ultrasound. Laparoscopy can sometimes help if the diagnosis is unclear, but it's not routine. And remember, any reproductive age female with abdominal or pelvic pain needs a pregnancy test first.
Who's at higher risk for PID?
Younger women, typically under 25, having multiple sexual partners or a partner with an STI, not using condoms consistently, and having a history of a previous STI or PID definitely bumps up the risk.
When do you need to admit someone with PID to the hospital?
Hospitalization is usually needed if symptoms are severe, like high fever, persistent vomiting, if you can't rule out a surgical emergency like appendicitis, if there are signs of peritonitis or a tubo-ovarian abscess, if they failed outpatient treatment, or if they're immunocompromised.
Okay, treatment. What are the typical antibiotic regimens?
For inpatient, common IV regimens are cefoxitin or cefotenin plus doxycycline, or clindamycin plus gentamicin. For outpatient, a good option is a single shot of ceftriaxone IM plus doxycycline by mouth for 14 days, sometimes with metronidazole added. Another outpatient choice is cefoxitin IM with probenecid, followed by oral doxycycline, again, maybe with metronidazole.
And partners.
Absolutely crucial to treat sexual partners empirically, even if they don't have symptoms. And the patient needs to abstain from intercourse during the full 14-day treatment course. Also important to screen for other STIs and offer HPV vaccination if needed.
Any key ward tips from the source?
Always think chlamydia and gonorrhea first with PID. Remember, it's a clinical diagnosis. And a common misconception, IEDs do not increase the overall risk of PID beyond the initial insertion period.
And that zebra alert mentioned Fitzhugh-Curtis.
Right, that's perihepatitis, inflammation around the liver capsule. It's a complication of PID, usually from chlamydia or gonorrhea, ascending into the abdomen. On laparoscopy, you might see those classic violin string adhesions between the liver and the abdominal wall.
Okay, let's break down some specific STIs. Gonorrhea, key organism.
Neisseria gonorrhea. It's a gram-negative diplococcus, kind of picky, grows on special Thayer-Martin agar in a CO2 environment.
Presentation.
Here's the tricky part. It's often asymptomatic, especially in women. If symptoms occur, it might be dysuria, increased vaginal discharge, cervicitis, but untreated, it can cause PID, chronic pain, ectopic pregnancy, infertility, and co-infection with chlamydia is super common.
Diagnosis and treatment.
Diagnosis is best with nucleic acid amplification tests, NATs on urine or swabs. Culture is possible but less sensitive. Treatment is now ceftriaxone 500 mg IM as a single dose, PLUS is azithromycin 1 gram orally as a single dose.
Why the dual therapy?
Two big reasons. Helps combat rising antibiotic resistance in gonorrhea and reliably treats chlamydia, which is often present concurrently. That dual therapy point is really high yield for exams. If someone has a severe cephalosporin allergy, azithromycin 2G orally as a single dose is an alternative, but you'd want a test of cure a week later. And again, treat partners. Gonorrhea is highly transmissible.
Got it. Next, chlamydia. How does it compare?
Chlamydia trachomatis. It's an obligate intracellular bacterium, and it's actually the most commonly reported STI in the U.S. Even more often asymptomatic than gonorrhea, particularly in females. When symptomatic, think mucopurulent discharge, cervicitis, urethritis.
Complications if untreated.
Very similar to gonorrhea. PID, Fitzhugh-Curtis, ectopic pregnancy risk, infertility, pelvic adhesions, chronic pain, serious stuff.
Diagnosis and treatment for chlamydia.
Diagnosis is again 8 ATs urine or swabs are preferred. Treatment is either doxycycline 100 milligrams twice a day for 7 days, or that single 1 gram dose of azithromycin. Treat partners.
Any preference between doxy and azithro?
Outside of pregnancy, both are effective first-line options. Doxycycline is generally preferred due to emerging azithromycin resistance, but azithromycin single dose improves compliance. In pregnancy, though, you must use azithromycin because doxycycline can stain the baby's developing teeth. Key exam point. Chlamydia is roughly twice as common as gonorrhea. And remember, Reiter syndrome conjunctivitis, urethritis, or arthritis can be triggered by chlamydia.
What about LGV, lymphogranuloma venereum?
That's caused by specific serotypes of chlamydia L1, L2, L3, more common in tropical areas. It has stages, starts with a painless little ulcer, then develops painful, swollen lymph nodes in the groin called buboes. Later stages can involve rectal strictures or fistulas. Diagnosis is NATE, and treatment is a longer course of doxycycline, usually 21 days.
Okay. Moving on to syphilis, the great imitator. Why that nickname?
Because treponema pallidum, the spirochete that causes it, can manifest in so many different ways, affecting almost any organ system, mimicking lots of other diseases. And it's tricky because you can't culture in a lab easily.
So how do you diagnose it?
Diagnosis usually starts with screening tests, non-treponemal tests like RPR or VVRL. These are useful but can have false positives. Things like viral infections, autoimmune diseases like lupus, even pregnancy can cause a false positive.
So if the RPR is positive,
You must confirm it with this specific treponemal test, like FTAABS or MHATP. These detect antibodies directly against the spirochete. In primary syphilis, if there's a chancre present, you might be able to see the spirochetes directly using dark field microscopy, but it's not always available or practical.
let's walk through the stages. Primary.
Primary syphilis shows up maybe 3 weeks after exposure. It's characterized by a single, painless, hard ulcer called a chancre at the site of infection. It heals on its own in 1–2 months, even without treatment.
Then secondary syphilis.
This appears weeks to months later. Classic sign is a generalized rash, often including the palms and soles. That's a big clue. You can also see condyloma lata, which are these moist, wart-like lesions in warm areas, mucus patches in the mouth, lymph nodes swelling, fever, feeling unwell. This stage also resolves spontaneously after a few weeks.
Then it goes quiet. Latent stage.
Exactly. Latent syphilis means the person has no symptoms, but their blood tests are positive. Early latent is within the first year of infection. Latent is after that.
And tertiary.
This is the late destructive stage, years later. Can involve gummas, soft tumor-like growths. Cardiovascular syphilis, classically causing aortic aneurysms. And neurosyphilis, affecting the brain and spinal cord.
Treatment. Is it penicillin for everything?
Pretty much. Penicillin G, specifically the long-acting benzathine penicillin G given as an injection, is the treatment of choice for all stages. The dose and number of injections depend on the stage. Primary, secondary, early latent usually get one dose. Late latent and tertiary need multiple doses.
What if someone's allergic to penicillin?
For non-pregnant patients with a documented penicillin allergy, doxycycline is usually the alternative. But, and this is critical for pregnant patients allergic to penicillin, you must desensitize them and then treat with penicillin. It's the only proven way to prevent congenital syphilis in the baby.
Anything else to watch out for with treatment?
Yes, the Jarisch-Herxheimer reaction. It's an acute, temporary reaction, fever, chills, headache, muscle aches that can happen within hours of the first penicillin dose. It's thought to be due to the release of toxins from the killed spirochetes. It's usually self-limited.
Key ward tips for syphilis.
Penicillin G is king. Screen with RPR-VDRL, always confirm with FTA, ABS, MHA, TP. Rash on palm soles after a painless genital ulcer. Think secondary syphilis. Remember, lupus can cause a false positive RPR.
All right, let's switch to viruses. Genital herpes, HSV-1 or HSV-2.
Most commonly HSV-2 for genital infections, but HSV-1 is causing an increasing proportion, maybe 15% or more now. It's a DNA virus. Sets up shop in the nerve ganglia for life.
How does it usually present?
It varies a lot. Some people are asymptomatic but can still shed the virus. A primary infection is often the worst systemic symptoms like fever, malaise, plus crops of painful vesicles that turn into ulcers. This happens maybe 1-3 weeks after exposure. Recurrent outbreaks are usually milder, shorter, often preceded by prodromal symptoms like tingling or burning.
What's a non-primary first episode?
That's when someone already has antibodies to one type of HSV, say HSV-1 from oral herpes, and then gets infected with HSV-2 genitally for the first time. The symptoms might be less severe than a true primary infection because of some cross-protective immunity.
Complications, besides being painful and recurrent.
Can cause aseptic meningitis, urinary retention due to pain or nerve involvement. Rarely disseminated herpes, especially in immunocompromised people.
Yeah.
The biggest concern, though, is neonatal herpes if a baby is exposed during vaginal delivery when the mother has active lesions or shedding.
How's it diagnosed?
Often clinically, just by the appearance of the lesions. Zinc smear looking for giant cells is historically mentioned, but has really low sensitivity. Viral culture from an unroofed vesicle used to be standard, but sensitivity is only about 50%. PCR testing of a swab from the lesion is now preferred, much more sensitive. Serologic tests like Western blot can detect antibodies and tell you if someone's been infected with HSV-1 or HSV-2 in the past.
Treatment. Can you cure it?
No cure, unfortunately. Treatment is palliative, aimed at reducing symptoms, duration, and frequency of outbreaks, and reducing shedding. Antivirals like acyclovir, velaciclovir, or famciclovir are used. For a primary outbreak, usually 7-10 days of treatment. For recurrent episodes, shorter courses like 5 days started early.
What about people with lots of outbreaks?
For them, daily suppressive therapy with one of the antivirals can be very effective at reducing the frequency and severity of recurrences, and also decreases asymptomatic shedding.
And in pregnancy.
Suppressive therapy is often started around 36 weeks gestation to minimize the chance of having an outbreak at the time of delivery. If there are active lesions or prodromal symptoms when labor starts, a cesarean section is recommended to prevent neonatal transmission. Exam tip: stress, illness, immunosuppression can trigger recurrences. Ward tip: culture or PCR, any painful genital lesion. Biopsy suspicious lesions you can't diagnose.
Okay. Quick points on HIV/AIDS for the shelf.
HIV is an RNA retrovirus, targets CD4 T cells, leading to immunodeficiency. Transmission is primarily through blood, semen, vaginal fluids, breast milk, sexual contact, shared needles, mother to child.
Diagnosis.
Standard is a 4th-generation test looking for both HIV antigen P24 and antibodies. A positive screen needs confirmation, usually with an HIV-1, HIV-2 antibody differentiation assay. If that's inconclusive or you suspect very early infection, an HIV viral load test, PCR, is done.
Treatment basics.
Combination antiretroviral therapy, HAART. multiple drugs targeting different parts of the virus life cycle. Goal is to suppress the viral load to undetectable levels and allow the CD4 count to recover. Monitor CD4 and viral load regularly.
Keyword tips regarding HIV.
Test all patients presenting with any STI for HIV. Remember, C-section for women with HIV if they have active herpes or prodrome at delivery. And with effective heart keeping the viral load undetectable, the risk of vertical transmission is very low, allowing for vaginal delivery in many cases.
HPV human papillomavirus, warts and cancer link.
Yep. Low-risk types, mainly 6 and 11, cause the vast majority of genital warts, or condylomata acuminata. High-risk types, especially 16 and 18, but also others like 31, 33, are the ones strongly linked to cervical cancer, as well as anal, vaginal, vulvar, and or laryngeal cancers.
How does it present?
Can be asymptomatic, detected only by an abnormal Pap test showing cervical dysplasia, or can cause visible warts. They vary a lot in appearance. Could be small, flat, or large, and cauliflower-like. Found on genitalia, perineum, anus, sometimes vagina or cervix. Warts can sometimes worsen during pregnancy or with immunosuppression.
Diagnosis and treatment.
Warts are usually diagnosed just by looking at them. Biopsy if they look unusual or don't respond to treatment. Cervical dysplasia is managed based on Pap and HPV test results according to specific guidelines. Wart treatment can involve patient-applied creams like podophyllotoxin or imiquimod, or provider treatments like cryotherapy, freezing, trichloroacetic acid, TCA, laser, or surgical removal.
And prevention.
The HPV vaccine is key for primary prevention. It protects against the most common high-risk and wart-causing types. It's recommended routinely for boys and girls around age 11-12, ideally before they become sexually active. It's given as a 2 or 3 dose series depending on age.
Okay, 2 less common ones quickly. Chancroid.
Caused by Haemophilus ducreyi, uncommon in the U.S. Classic presentation is 1 or more painful genital ulcers, often soft, ragged edges, gray base, plus painful swollen lymph nodes in the groin, buboes. Gram stain might show school of fish bacteria, but sensitivity is low. Culture needs special media. Treatment is usually a single dose of ceftriaxone or azithromycin. Painful ulcer, think chancroid, covers painless chancre of syphilis.
And pediculus pubis, crabs.
Infestation with the pubic louse, Phathyrus pubis. Main symptom is intense itching in the pubic region but can affect other hairy areas. Spread by close physical, usually sexual contact. Diagnosed by seeing the lice or their nits, eggs on the hairs. Treatment is with topical creams or shampoos containing pyrethrins or permethrin. Need to wash bedding clothing in hot water. Lindane shampoo is an older option but generally avoided now, especially in pregnancy, due to neurotoxicity concerns.
All right, let's wrap this section with vaginitis and vaginosis. Big 3. Trichomonas, BV, yeast. How do we tell them apart?
Okay, trichomoniasis first. Caused by Trichomonas vaginalis, a motile protozoan. It is sexually transmitted. Classic symptom is a copious, frothy, yellow-green, malodorous discharge. Often causes itching, irritation, sometimes painful urination. You might see a strawberry cervix, little red spots, or petechia on the cervix.
Diagnosis and treatment for Trich.
Diagnosis is usually by seeing this swimming trichomonads on a wet mount slide under the microscope. Vaginal pH is typically elevated, 4.5. The whiff test, adding KOH, might be positive or negative. Treatment is metronidazole, usually orally. Crucially, you must treat sexual partners too, and tell patients to avoid alcohol while taking metronidazole due to a potential disulfiram-like reaction. Exam tip: strawberry cervix or frothy discharge, think trichomonas.
Okay, next, bacterial vaginosis, BV. Is this an STI?
No, BV isn't considered an STI. It's a shift in the vaginal flora, an overgrowth of certain bacteria, especially Gardnerella vaginalis, and a decrease in the normal protective lactobacillus species.
Main symptom.
The hallmark is a malodorous discharge, typically described as fishy, especially noticeable after sex or during menses. The discharge itself is usually thin, grayish-white, and coats the vaginal walls. Itching is less common than with Trich or yeast.
Diagnosis. Amsel criteria.
Yeah, right. You need 3 out of 4 Amsel criteria. 1, homogeneous thin grayish-white discharge. 2, vaginal pH 4.5. 3, positive whiff test, that fishy amine odor when you add KOH to the discharge. 4, presence of clue cells on the wet mount vaginal epithelial cells studded with bacteria obscuring the borders.
Treatment for BV partners.
Treatment is usually metronidazole, oral or vaginal gel, or clindamycin, oral or vaginal cream. Unlike trichomonas, routine treatment of male partners is not recommended as it doesn't seem to prevent recurrence in the woman. Exam tip: clue cells on wet prep, even BV. Most common symptom is the odor.
And finally, candidiasis, or yeast infection.
Usually caused by Candida albicans, though other species can be involved. It's an overgrowth of yeast that's normally present in small amounts.
Classic symptoms.
Intense itching, pruritus, is the main one. Also burning, soreness, redness, swelling of the vulva. The discharge is typically thick, white, clumpy, often described as looking like cottage cheese. And importantly, it's usually odorless. Painful intercourse can occur too.
Diagnosis.
Diagnosis is confirmed by seeing budding yeast or pseudohyphae on a wet mount, prepared with 10% KOH. The KOH dissolves other cells, making the yeast easier to see. Vaginal pH is typically normal in the 4.0–4.5 range. Whiff test is negative.
Treatment.
Antifungals. Lots of options. Topical creams or suppositories like clotrimazole, meconazole, available over the counter or by prescription, or a single oral dose of fluconazole. Partner treatment usually isn't needed unless the partner also has symptoms. Exam tip: hyphae on KOH prep equals yeast. Most common symptom is itching.
Any other causes or tips for vaginitis?
Things like recent antibiotic use, douching, sometimes intercourse itself can disrupt the normal flora and predispose to BV or yeast. A forgotten tampon or other foreign body can cause a foul discharge. Ward tip: the whiff test is really helpful for BV. Diagnosis is largely clinical, based on symptoms and microscopy. Oh, and if you see sulfur granules on a pap smear, especially with an IUD, think actinomyces, though it's often just colonization.
Wow, that was a huge amount of high-yield detail on GTD and STS vaginitis. Before we tackle breast disease, what are the absolute must-knows, the things you absolutely have to retain from this for the shelf?
For GTD, nail the differences between complete and partial moles genetics, paternal versus maternal paternal, fetal tissue, no versus yes, risk of GTN. Recognize the mole presentation: bleeding, size dates, high HCG, snowstorm US. No choreo, uses the trophoblast, no villi, often post-nonmolar pregnancy. For SE sagittitis, know the main bug for each: gonorrhea, chlamydia, syphilis, herpes, HPV, trich, beefy, yeast. Know the classic presentations: asymptomatic is common for CG, painful versus painless ulcers. Discharge characteristics: diagnosis NADATs are key for CG. RPO-VDRL screen, FTA, ABS confirmed for syphilis. PENG for syphilis, desensitize if pregnant and allergic. Metronidazole for trich, treat partners. And BV, no partner TX. Antifungals for yeast, those are the big ones.
Excellent distillation. Okay, let's shift focus to breast disease. The goal here is separating benign from malignant, right?
Absolutely. Key goals are managing benign symptoms, reliably telling benign from malignant conditions, and identifying women at higher risk for breast cancer who might need different screening or management. Knowing basic anatomy helps: lobes, ducts draining to the nipple, lymph drainage mostly to the axilla.
Let's talk screening for average risk women. What are the current recommendations?
It's a combination. Breast self-awareness is encouraged, knowing what's normal for you. Routine monthly self-exams aren't strongly pushed anymore, but awareness is key. Clinical breast exams, CBE, by a provider, ASO and CCN, suggest every 1–3 years for ages 25–39, then annually from 40 onwards. And mammography.
Mammogram guidelines seem to vary a bit.
They do. Generally, discussion starts around age 40. Some guidelines recommend starting annual screening at 40, others at 45 or 50, maybe switching to biannual screening later. Most agree screening continues until about age 75, then it's more individualized. It's really about shared decision-making, weighing the benefits of early detection against risks like false positives, anxiety, and potential overdiagnosis.
Remind us of the major risk factors for breast cancer.
Family history is big, especially first-degree relatives. Genetic mutations like BRCA12, hormonal factors, early menarche, late menopause, never having children or having first child after 30, not breastfeeding, lifestyle factors like alcohol use, obesity, inactivity, increasing age is a major one, and prior chest radiation or history of certain benign breast conditions. Lifetime risk is about 1 in 8 for U.S. women.
Okay, someone comes in with a palpable breast mass. What's the workup?
Starts with a good history and careful clinical breast exam, then imaging. For women under 35, ultrasound is often the first step. For 35 and older, usually both mammogram and ultrasound are done. If the mass looks suspicious on exam or imaging, or if it's solid, a biopsy is typically needed.
Biopsy options.
Fine needle aspiration, FNA, or more commonly now a core needle biopsy, which gives more tissue architecture. Imaging findings are often reported using the BRAD score from 0 incomplete to 6, known malignancy, to standardized risk assessment. In very young women with a clinically benign appearing mass and reassuring ultrasound, biopsy might sometimes be deferred.
What are some common benign things that cause breast masses?
Simple cysts are very common, especially premenopausally. They're fluid-filled, often round, mobile, maybe tender, can change with the cycle. Fat necrosis can happen after trauma or surgery, feels from, sometimes tender, can mimic cancer. Fibroadenomas are super common, benign, solid tumors in younger women. 20s, 30s typically feel rubbery, smooth, mobile, well-defined.
Any others?
Fibroadenomas are rarer, related to fibroadenomas, but can be larger and occur in slightly older women. They need excision because they can be borderline or malignant. And fibrocystic changes, that's a broad term for general lumpiness, nodularity, maybe pain, often cyclical, usually benign, and doesn't increase cancer risk significantly on its own.
What findings on exam or imaging make you worry about malignancy?
On exam, a mass that's hard, fixed, stuck to skin or chest wall. Irregular borders, larger size, 2 centimeters. Skin changes like dimpling or retraction, new nipple inversion. On mammogram, a spiculated mass is highly suspicious. Also concerning are irregular calcifications, architectural distortion, asymmetric density. Ward tip, simple cysts most common benign finding overall, 35-50. Fibroadenoma is most common in adolescents, young women.
What about nipple discharge? When is it concerning?
Discharge is more likely benign if it's bilateral, only happens with manipulation squeezing, comes from multiple ducts, and is milky or greenish. It's more suspicious if it's unilateral, spontaneous, happens on its own, from a single duct, and especially if it's bloody or clear serosanguinous.
What causes benign discharge?
Physiologic discharge can be various colors. Galactorrhea is milky discharge, usually bilateral, often due to high prolactin levels from meds, pituitary issues, etc. An intraductal papilloma is a benign growth in a duct that classically causes unilateral bloody or serous discharge from a single duct.
Breast pain, nostalgia, common complaint, usually cancer.
Rarely. Breast pain alone is usually not cancer. Need to ask about timing, cyclical. Duration, hormone use, caffeine intake, trauma. Cyclical pain is usually bilateral, worst in the luteal phase, related to hormones. Non-cyclical pain is often unilateral, not related to the cycle, could be from large breasts, a cyst, mastitis, trauma, sometimes meds, or it could be extramural pain from the chest wall, costochondritis, etc.
Treatment for pain.
Mostly reassurance. Reducing caffeine might help some. Good supportive bra, NSAIDs or acetaminophen, warm or cool compresses. Evening primrose oil is sometimes tried. Imaging usually only if there's a palpable finding or the concern. OCPs can sometimes cause breast pain.
Lastly, breast skin changes to watch for.
Look for any redness, swelling, edema like peau d'orange, dimpling, retraction. Eczema-like changes or ulceration around the nipple could be Paget's disease of the nipple, associated with underlying cancer. Diffuse redness, warmth, tenderness, skin thickening can signal inflammatory breast cancer and emergency. Localized redness, warmth, tenderness, maybe a fluctuant mass suggests mastitis or abscess needs antibiotics, maybe drainage.
Okay, excellent overview of breast issues. Let's broaden the scope now to general female patient health maintenance and screening, so critical for prevention.
Absolutely. Preventative care is huge. Let's recap some key screening guidelines for average risk women. Cervical cancer. Start cytology, PAP, at 21, every 3 years until 29. Then from 30-65, options are cytology Key5 or primary high-risk HPV testing Key5Y or co-testing PAP plus HPV Key5Y. Stop screening after 65 if prior screens were adequate and negative. No screening needed after hysterectomy for benign reasons if no history of high-grade lesions.
Breast cancer screening we covered. Osteoporosis.
Radicular scan for bone mineral density starting at age 65 for all women. Younger postmenopausal women, 65, should be screened if they have significant risk factors like prior fragility fracture, family history of hip fracture, low body weight, smoking, heavy alcohol use, rheumatoid arthritis, long-term steroid use.
Colorectal cancer.
Start screening at age 45 for average risk. Continue to 75. Options include stool tests like FIT annually or MTS DNA Q3Y, or visual exams like colonoscopy Q10Y or CT colonography Q5Y. Screening decisions between 75 and 85 are individualized. Generally stop after 85. STI screening. Risk-based assessment for everyone, but specifically annual chlamydia and gonorrhea screening for all sexually active women under 25 and older women with risk factors, new multiple partners, etc. HIV testing at least once for everyone aged 13-64, more often based on risk. Usually screened for chlamydia and gonorrhea together.
Beyond screening tests, what about health education topics?
Nutrition and exercise are fundamental. Promote balanced diets, portion control, limiting processed foods, sugars, saturated fats. Encourage regular physical activity. Aim for 150 minutes moderate aerobic plus strength training twice a week. Screen for substance. Use alcohol. Cage questions. Tobacco vaping. Use the 5 A's. Ask, advise, assess, assist, arrange. Discuss risks of prenatal alcohol exposure. FASD.
Safer sex and violence screening, too.
Definitely. Talk about safer sex abstinence, condoms, contraception, including emergency contraception, EC. Create a safe space for these talks. Screen all women for intimate partner violence, IPV. Know the signs, ask directly but sensitively. Assess safety, offer resources, document carefully. Remember, the highest risk period for IPV homicide is often when the person attempts to leave. Also be prepared to manage sexual assault disclosures, medical care, STI testing prophylaxis, EC, injury documentation, legal aspects, consent, evidence collection, psychological support.
Female sexual function.
Yes, this should be part of routine care. Approach sensitively, using inclusive language. Understand the sexual response cycle. Desire, arousal, orgasm, resolution, though it's not always linear. Ask about dysfunction issues with interest, arousal, orgasm, or pain, genitopelvic pain penetration disorder.
Yeah.
Evaluate for underlying medical conditions, medications, SSRIs, or common culprits. Relationship issues, psychological factors, menopause. Management involves treating underlying causes, maybe counseling, lubricants, pelvic floor PT, sometimes adjusting meds or addressing hormone levels.
Let's touch on ethics briefly. Key principles.
Respecting patient autonomy is central. Understanding patient preferences, often formalized through advanced directives like living wills, specifying care wishes if incapacitated, and durable power of attorney for healthcare, designating a decision maker. Informed consent is crucial, ensuring the patient understands risks, benefits, alternatives before agreeing to treatment, and that they have capacity to decide. Exceptions exist, like emergencies. Patient confidentiality is vital, protecting health information, with legal exceptions for harm risks, communicable diseases, etc. Navigating minor consent and confidentiality requires balancing autonomy with safety and parental rights depending on the situation and local laws. Good documentation is key for everything.
Okay, nearing the end. Let's tackle menopause and pelvic relaxation. Common issues later in life. Menopause first.
Menopause is defined as 12 consecutive months without a period, average age around 51, 52. It's due to ovarian follicular depletion, the ovaries run out of responsive eggs, estrogen levels plummet, and FSH levels rise, trying to stimulate the ovaries.
Main symptoms.
The classic ones are vasomotor symptoms, hot flashes, and night sweats, and genitourinary syndrome of menopause, GSM, which includes vaginal dryness, itching, pain with intercourse, dyspareunia due to vaginal atrophy.
Long-term consequences of low estrogen.
Increased bone loss, leading to osteoporosis and fracture risk. Changes in lipid profiles can increase cardiovascular disease risk. Changes in body composition, more central fat, less muscle mass. Mood changes, sleep disturbances are also common. Remember the acronym HAVOC, hot flashes, atrophy of vagina, osteoporosis, coronary artery disease.
How do you manage menopause symptoms? Hormone therapy.
Menopausal hormone therapy, MHT, estrogen, or estrogen plus progestin, if the woman still has her uterus, is the most effective treatment for moderate to severe vasomotor symptoms. It's generally considered safe for healthy women under 60 or within 10 years of menopause onset, used at the lowest effective dose for the shortest appropriate duration.
What about risks of MHT, WHI study?
The WHI study showed increased risks like VTE, stroke, breast cancer with E plus P, particularly in older women or those starting MHT many years after menopause. The risk-benefit balance is generally more favorable for younger, recently menopausal women for vasomotor symptom relief. MHT is not recommended solely for chronic disease prevention. There are contraindications, history of breast cancer, VTE, stroke, active liver disease, unexplained bleeding.
Other options besides hormones?
For vasomotor symptoms, SSRIs and Is like venlafaxine, paroxetine, gabapentin, or clonidine can help. For GSM, first line are non-hormonal lubricants and moisturizers. If those aren't enough, low-dose vaginal estrogen, creams, tablets, rings, or vaginal DHEA is very effective and has minimal systemic absorption. For osteoporosis prevention treatment, lifestyle, calcium, Vit D, exercise, smoking cessation, plus meds like bisphosphonates, first-line serums, raloxifene, etc. MHT isn't first-line just for bones.
Got it. Finally, pelvic relaxation or pelvic organ prolapse.
This is when pelvic organs, bladder, rectum, uterus, or the top of the vagina after hysterectomy descend or bulge into the vagina due to weakened support structures.
Yeah.
Types include cystocele, anterior wall, bladder, rectocele, posterior wall, rectum, enterocele, small bowel, uterine prolapse.
Who gets it? Symptoms?
More common with increasing age, especially postmenopausal, higher parity, more vaginal births, obesity, chronic cough or constipation, genetics play roles. Symptoms include a feeling of pelvic pressure or heaviness, a bulge sensation, problems with urination, incomplete emptying completion, or defecation, splinting, sexual dysfunction.
How's it diagnosed and treated?
Diagnosis is by pelvic exam, seeing the prolapse, often assessed with straining and in different positions. Systems like POPQ quantify the descent. Treatment depends on symptoms. Asymptomatic prolapse often needs no treatment, just observation. Symptomatic prolapse can be managed non-surgically with pelvic floor muscle training, Kegels, or a pessary a device inserted into the vagina to support the organs. Surgical repair, like anterior colporrhaphy for cystocele, is an option for symptomatic women who failed or declined conservative management, usually after childbearing is complete.
This deep dive has been incredibly thorough, hitting so many high-yield points for the OBGYN shelf, all grounded in first aid. Hopefully this helps solidify these crucial concepts for everyone listening. Definitely review areas you felt shaky on, and notice the connections between topics.
Absolutely. We tried to pull out the most critical info to streamline your prep. Keep reviewing, make sure the fundamentals are strong.
And maybe a final thought to chew on. Considering how interconnected everything is, can you think of one clear example where understanding the underlying physiology, say, hormonal changes in menopause directly impacts how you understand and manage seemingly unrelated conditions, like maybe GSM, bone health, and mood changes all at the same time? Something to ponder as you connect the dots. Thanks for joining us on this deep dive.